in 2024. A graduate of UBC Medical School and completed his Emergency Medicine Enhanced Skills Program at UBC in 2004. He also completed a fellowship in hospice and palliative care at Stanford University in 2014. His areas of interest include palliative care in humanitarian crises, point-of-care ultrasound, medical education, and psychedelic-assisted therapy for patients with palliative needs. It brings a particularly valuable perspective to today's conversation because of his experience in both emergency medicine and palliative care. And now it is my pleasure to hand over the session to you, David. Thank you.
Okay. Thanks, Esther. I'll just share my screen. How does that look, Esther?
Yeah, it's coming up. All good.
Okay. Thanks everyone for attending, and I'll get going so that there's lots of room at the end for discussion. And I just want to start with this slide. I was approached to give this talk some months ago, and I'm a reluctant watcher of season 2 of the Pitt. I will admit that, because like a lot of us who hail from the emergency room, we're not really wanting to watch any extra emergency medicine topics when we're not working. But my long-suffering wife is a big fan of the Pitt. She's not medical, but she's kind of a doctor by proxy now after all this time together. And I stubbornly, but happily now watched season 2, and I thought it was really good. So this little scene does maybe portray how some of us historically and maybe currently approach some palliative emergencies and needs truly in the ER. They can be very difficult. We're not really set up and historically trained to look after patients with palliative needs in our curriculum. So we look at each other, we scratch our heads, and we wonder how we can help. So we're going to talk about how that's progressing and what the current lay of the land is. And so an acknowledgement to the Pitt for actually making some of these topics real amidst all the more sexy topics such as trauma. So I have modest objectives for today. So I'm going to talk about the current state of affairs in Canadian EDs. I'm going to talk about 2 real cases from last week that I participated in. I'm going to discuss education in terms of palliative care and emergency medicine and how they interface. We'll discuss some pre-hospital palliative care initiatives and some other future initiatives with some time for questions. I too had a land acknowledgement, but I will skip it because we've already had one. But I did do most of the work for this deck in Squamish Nation, where I live. Just some quick disclosures. I really don't have any financial disclosures at all. I did do some training for BC EHS, BC Ambulance in the past. I no longer am actively involved with that. I was a former facilitator for Pallium Canada and no longer, but I am a current UBC faculty member for both emergency medicine and palliative care. And I guess the other important disclosure is that, you know, in some ways I'm a tiny bit of a fraud because even though I worked for 20 years full-time emergency medicine, I did stop 2 summers ago. That being said, I am in the emergency room a lot in my role as a palliative care doctor at St. Paul's. So with that, all those disclosures, I'm going to talk about the current landscape. So the reality of emergency medicine in 2026 is that it's a tough place to be cared for. I miss it greatly. It was a great place to work. I worked with a fantastic team for a long time, and I miss them dearly. But the reality is that emergency rooms are very loud. They're hard on privacy. There isn't a lot of space. The waits can be long. There are gaps of information, and those gaps of information are due to lots of reasons, such as we don't have a unified electronic medical record in the province. Some places are still using paper. It's really hard to share information and to gather information in a timely fashion. I feel very grateful personally that in Vancouver, we share a lot of the same electronic medical record amongst the cancer agency and a lot of the big hospitals. So I feel very lucky for that. We also have knowledge and skills gaps. We have that. I think, a humble emergency doctor will acknowledge an emergency provider that we all have gaps that we need to work on. And so we do have gaps when it comes to palliative care. A really important center of this screen is that a lot of patients with palliative needs with cancer, and of course, I'm not just going to talk about cancer, but a lot of people with palliative needs when it comes to their cancer come into the emergency department in the last 3 months of their lives. So I think it's really important to be good at the skills to look after these patients when they come in, because they are coming in. Most are coming in. This is an article from a few years ago. It's actually out of England. It's a single site article. It's actually almost 10 years old. And this statement alone is reflective of a lot of what we hear in the emergency room around people coming in with palliative care needs. So should they be here or not? And that's a valid question. We would love, I think most patients would love not to have to come into the emergency room. But what this single site study discussed was that sometimes it's just needed. There are things you cannot handle at home in a long-term care facility. And I would argue, a couple times a year, I have to send people back from hospice to hospital for things you cannot handle in place. So all this to say, the truth is that people are coming through the door and we need to be prepared. So I want to talk about a really important word in Canadian healthcare, and that is access. So when we talk about the broken system in Canadian healthcare, I feel a bit challenged by that statement. I think a lot of things are compromised and broken for sure. But I think once you get access to your services, whatever they may be, I think the care is really good. And I'm very proud of that. But there's no arguing that access to care is difficult. It's represented in the long wait times you see in the emergency room, because a lot of people, frankly, can't get into other access points in the system. So without creating a long laundry list, I'm sure a lot of you are experiencing it, whether you're waiting for a surgery or a procedure or a medicine. But for palliative care, we often have access issues that are affected by geography, specialty access, training, etc. So I know I'm preaching to the converted here. So there are other factors that affect how things occur in the emergency room, and I just want to be really focused on this. So in the 20 years that I did this job, I watched this all occur in real time. The population got older. We knew it was coming. It has come, and it will only get worse. With that, a lot of people would initially present with maybe one or two other medical problems in their history. And it's really common now to have people with 10 plus concurrent medical issues and let's say 20 concurrent medications. And they'll present with a chief complaint, chest pain, shortness of breath, headache, generalized weakness. But they have a background of significant medical comorbidities, in part due to survivorship. Let's face it, our technology has gotten really good. People survive their strokes, their heart attacks, their first cancer diagnoses, maybe their second one. People are living longer with these illnesses. Another issue that's really come to light of late, and I see this all the time, especially in the last 5 years, are earlier cancer diagnoses. And what I mean by earlier are younger people are getting cancer. And that's a reality. It's not uncommon for me to look after patients as an adult palliative care doctor, people in their 20s, 30s, and early 40s. That is the reality. It's scary, but I'm seeing it. And then lastly, probably everyone knows this, access to primary care, I hope is getting better. I think it's getting better. I applaud all the family doctors out there. I'm blessed to have a great family doctor whom I can get into. But primary care access is an issue, and it was really highlighted during COVID, where the emergency rooms really hit a very tricky tipping point. Um, and then there's this. So this is a decent slide. It's not really up to date when it comes to like what is happening, but the fentanyl crisis is a reality. I just took over care of a patient this morning who about 25 days ago had an out of hospital cardiac arrest due to an overdose and is now funneled through the critical care system, has no meaningful neurological recovery predicted, and is getting best supportive care by our team now. And this gentleman is in a long line of, I don't know how many people in the last 5 to 7 years who have come to me as a palliative care doctor. They're in our emergency rooms all the time. And this is a big factor that we talk about, and I'll highlight it that it affects palliative care as well. So I want to talk about a couple of cases from last week. And this is Noah Wiley having fun. I like to have fun at work too, even on the palliative care ward. I don't know if I do this very often and spin wheelchairs. This is a very common case. So this is someone from last week, an 80-year-old male who's got a background history of very severe cognitive impairment from a long-term care facility, is found by staff at about 11 p.m., quite hypoxic, so low oxygen levels on rounds, had been well earlier in the evening. His level of intervention was DNR level 2, and what that means here is that the patient is only to be transferred to an acute care facility if the issues cannot be handled in their place of residence. So in this term, this long-term care facility. The family was contacted and they wished for the patient to be assessed in the emergency room. And then the ambulance was called and the patient was brought into the emergency room in the middle of the night and seen by our emergency medicine colleagues. Case 2. I've changed a couple of identifiers with this patient just because I think it's important and she's got a rare problem. So this is a 47-year-old female with a 5-day history of jaw weakness, problems holding a fork in her mouth, and changes in her voice. Background history of thymic cancer, so a cancer of her thymus gland, a thymoma. She's been navigating this for 10 years and largely followed from the team in Toronto, actually. She's known to our team because she's about 6 weeks post surgery for a spinal cord compression, which was diagnosed on our unit and was sent to our spine colleagues at Vancouver General Hospital, and they fixed her beautifully, and she had been home doing well. Importantly, she's got a background history of anxiety for a long time, a lot of it related actually to her diagnosis. She is always on opioids for pain, especially recovering from her surgery. And then she, related to her anxiety, is on chronic benzodiazepines, so medications like lorazepam, but she's on clonazepam. So she's brought in, and I'm contacted because she's known by our team, and we can currently look after this woman, and she has a CT scan of her head, neck, and chest to assess what could be going on, maybe stroke, progression of disease. These tests were negative, and the labs were essentially normal. So we'll get back to both of these cases at the end. So those are 2 real cases from last week. So the question is, what does this have to do with palliative care, truly? Well, a lot, actually. So a really important takeaway from today is that modern palliative care is upstream. Okay, so what we historically may have thought about with palliative care, I think is very different in 2026. It's been different for some time. We are having touch points with patients way earlier in their disease navigation. So when it comes to the emergency room, we take a great deal of pride in being good cardiologists, pediatricians, orthopedic surgeons, trauma doctors. The part of our core training includes all of those specialties. We have to know how to deal with cardiac emergencies, pediatric emergencies, trauma, of course, etc. And there's a long list. What is not historically emphasized are patients with palliative care needs in our curriculum. Okay, but primary palliative care, just like primary pediatrics, knowing how to read an ECG and know how to deal with chest pain is core emergency medicine. Primary palliative care and how to deal with patients who have palliative needs and, in fact, palliative emergencies. They're an essential skill for not just emergency medicine physicians, but for emergency medicine staff. So this is everyone from triage, pre-hospital, in the hospital. This is a huge priority based on our current needs. As emergency medicine providers, though, we have some conflicts with palliative care inherently. We're there actually to save lives and get people better. Roughly 80% or more people actually go home from the emergency room every day. So the vast majority of people we send home, we want to treat them, we want to get them home, we want to get them better. Okay. But sometimes we can't do that, and we have some conflicts with patients who present with palliative needs. One common concern is, am I doing the right thing for this patient at this time? Am I doing too much? And we are encouraged in medicine to do as much as we can for the individual so that we can help them. So that's a lot of tests, a lot of treatments, and sometimes some life-sustaining therapies that lead to maybe a question, am I doing the right thing for this patient right now? And subsequent to that, we don't always feel equipped in the emergency room to be the person to have a goals of care conversation. We have episodic care. We don't know the patient. We don't have a relationship. We may not know everything about them. So determining the life and death trajectory of a patient in terms of goals can be really, really tricky. Can we provide a prognosis? Well, prognostication, even for specialty areas of medicine such as oncology, and I would say palliative care, critical care, prognosis is hard for the best of us. And I think most of us who are experienced are very humble around prognosis. Asking people in the emergency room around prognosis, it's really just tricky. And then in the emergency room, will I be able to link a patient with the care team that they need? We diagnose people fairly routinely with pancreatic cancers, let's say, and they present with painless jaundice. And we need to link them up with the team that can look after that person for that time. So that can be hard. I'm using an example, and this is not uncommon. So what we think about in emergency medicine and what we think about on the Pitt, and this is where the Pitt is probably good, is that the reality of emergency medicine is that it's not as sexy as it may seem at times. So what do we actually see on a day-to-day, week-to-week basis in the ER? We see medical trajectories gone wrong. So a lot of the focus of our training, I'll just skip a slide forward, is about the top left category of care. So these are cardiac arrests, traumas, where people go from being really good to really not good quickly, and we have a very limited time to work with. That's only about 15% of deaths. So 85% of deaths actually come from other things that have nothing to do with the real historical emergencies that we really like. So what do we truly see? We see cancer, we see organ failure, and we see frailty. That is the reality, and it's been the reality for some time. So outline these four major death trajectories on the top right. That's a classic one for cancer. So we see people who go along for a bit, depending on the type of cancer they may have, but they hit an inflection point. I don't know if you can see my cursor or not, but they hit an inflection point, and then there are more needs towards a decline. Organ failure. So these are everyday events in the emergency room. So people with heart failure, COPD, chronic kidney disease, chronic liver failure. These people come in and they have dips in their care. So they might have a small heart attack, an arrhythmia. We get them better. we get them back home, but they're not quite at the baseline they came in with. And this goes along for some time. This is a lot of what we see in the emergency room. And then frailty. So frailty, such as dementia, people start at a fairly low functioning position. And then in North America, they can last a median of 7 years in this frailty pattern with things like Alzheimer's dementia. So that's a lot of potential visits to the emergency room. So what can we do in the ED? Well, we can identify patients with palliative needs. Okay, so there are people that need palliative care. We need to pick them out of the crew, and we need to identify them, link them up with resources. Maybe they need admission. We can initiate goals of care conversations in the emergency room. We can try if we feel empowered to do so. What we always should prioritize is good, solid symptom management. So this is where there's an overlap between emergency medicine and palliative care. Truly, we need to be good at pain and nausea and shortness of breath and core symptoms that people present with when they need us. We can play a part in reducing unneeded interventions. That can be blood tests, that can be scans, that can be, admissions to the critical care unit, being on a ventilator. So we can play a part in this. As I said earlier, we can link people with palliative care if appropriate. So palliative care in the hospital, in the community, etc. The other piece is we can educate and mentor our teams and learners, which is what led me to take a sabbatical and go back and do more specialty training in the emergency room or in palliative care about 10 years into my career. So let's talk about what we're doing. And this is not an exhaustive list. I'm just going to provide a couple of examples. Before I go to that, I just want to give kudos to the Lionsgate Hospital Foundation, who more than 13 years ago provided a donation and initiative towards this project at UBC. And they were early identifiers in terms of needs assessment for educating emergency medicine trainees in palliative care. So thanks again to that team. This is quite a while ago now. This is about 10 years ago. This is a poster presentation that I'll show you led to a paper that I was part of with our emergency medicine colleagues in interior health. It talked about what is actually going on in the country in palliative and end-of-life care education in our emergency medicine residency programs. So in Canada, we have two discrete pathways that overlap a bit in terms of becoming emergency medicine physicians. So this surveyed across all programs. What it highlighted is that most of the time, there was not curriculum for palliative care in their 3 or 5 year training opportunities. Okay. So we published a paper in the Canadian Journal of Emergency Medicine subsequently around this topic. So before I move on to paramedics, this is an area of improvement. I was part of the CAPE subcommittee for palliative care and emergency medicine. CAPE is the Canadian Association of Emergency Physicians. And there are a small group of us in the country, I'm pretty sure we're still less than 20, I could be wrong, that are trained in both emergency medicine and palliative care and practice both. So this well-meaning group that I had the honor of being part of for some time really worked hard to advocate for this. And again, we're dwarfed by some of the other bigger groups and specialty groups in emergency medicine, but yeah, we're still working. I'm more of a legacy member now. BC Ambulance, we're just going to talk locally now, has an initiative going on with palliative care in place delivered by paramedics. So I had the honor of being part of this program. It stopped in 2019. I'm sure it's ongoing, but I haven't reached out recently. And this originally stemmed from a project that was successful in the Maritimes. And so I believe the BC Centre for Palliative Care was also part of this initiative and funding. So thank you to them as well. And it was a great project. I felt really honored to be part of it. So advanced care paramedics were able to provide palliative care in place when people called an ambulance and people were identified with palliative needs. Those could be symptom needs, they could be other needs. And so an excellent project. So the objectives of the project were to treat people in line with their goals and their wishes in place. It reduced people getting actually brought in, so the conveyance brought into the emergency room, and increased patient satisfaction with place of death if they're in fact dying. I want to talk about simulation. So simulation is an important part of medical education training in all specialties, but in emergency medicine, I find it just a fantastic tool to get people working. So basically, it creates scenarios and you run through a simulation in a lab with mannequins that are lifelike. So what we've done, and we've done for some time, is have emergency medicine simulations where there are palliative themes. So there can be palliative emergencies, such as high calcium emergencies, defibrillators going off that need to be turned off, and then communication opportunities. So if you've ever been on the other end of poor communication, so either personally, at work, if you get bad communication, it's hard to step back from that. And truthfully, when I left my residency, you're not really trained as well in communication, leaving in 2004. You do your best and you learn from your mistakes. That was my experience. So I took a lot of pride, and I continue to take a lot of pride in communication, but I'm always learning. What simulation does is it allows you to learn with supervision and coaching, where the consequences are not high. The consequences are really high when you're breaking bad news, when you're disclosing death, bad diagnoses after CT, so these are things that really need to be emphasized. So we're trying to promote this and continue it going forward. It takes a lot of work because it's really, again, it's not sexy. It's not the same as putting in a pacemaker. It's not the same as intubating, but I think it's no less important. An area of improvement in our practice in the emergency room, and I can't emphasize this enough, are 24-hour-a-day access to medical interpreters. So we live, obviously, in a very multicultural country. And where I used to work emergency medicine, we were one of the early adopters to real-time iPad interpreters, more than 200 real-time human on the other end interpreters, not AI, to help us with communication. So you can only imagine how much better life has been. It's not the same as an in-person interpreter. It is different, but it does avoid the use of family and friends providing translation when you're trying to navigate questions and communication. I do find it a bit limiting sometimes in terms of palliative care, because we don't always have the same words in different languages for things like hospice. Okay, so you really have to work hard to know what is actually being said to the other party. But I personally, I couldn't live without medical interpreters at work, and I think it's a huge improvement. So one topic that most emergency medicine providers, and frankly, a lot of other providers in the hospital struggle with, is how does one introduce palliative care as a topic? Palliative care inherently is scary. The specialty itself has thought for some time about changing its name, getting a new branding officer, because the brand of palliative care is scary to most people. So this is a struggle. And, I've over the years, I've had to come up with different ways specifically to make this topic less spicy. One way that I think is important to distinguish for everyone is acknowledging that palliative care and hospice care are different. Okay, so this may seem really obvious to a lot of people on the call, and that's okay. But I will tell you that a lot of people do not distinguish between palliative care and hospice care. I do emphasize that palliative care is care for the living. Okay, so you're very much alive and you need help. This is the team to help you. Hospice care is care for people who are preparing to die and they're in their last maybe 3 months or less to live. That is very different. So, my fellowship from the States actually distinguishes it, the American Academy of Hospice and Palliative Care. It spells it out. And actually, in the States, it's really quite separate. For those of you who've trained or worked in the States, you know this. It's actually quite separate. And again, getting to that theme of palliative care is upstream. And I really emphasize, depending on the scenario, that I'm not asking the palliative care team to be involved because you're dying, but rather you're very much alive and you need help with your pain, your nausea, extra layer of support. The other piece too, most people are very scared and worried about talking about DNR. That's a scary topic. And one thing to emphasize, there's lots of things to emphasize about DNR. I'm not going to tell you that it's not scary. It kind of is. But DNR is not synonymous with do not intervene, and do not care. So people who have a DNR, we intervene all the time. We're doing stuff all the time. There are different levels, and if we want to, we can talk about it during the chat. But DNR does not mean do not intervene. And really, really importantly, it doesn't mean we do not care. DNC does not apply to DNR. We're always going to care. A lot of people worry about medical abandonment when they sign a DNR. Okay. And when I talk about the conclusion of that young person that I saw last week, we'll talk about how DNR can be fluid as well. Very quickly, advanced care planning versus goals of care. One really important initiative and part of the training that I do as a preceptor in the different parts of UBC is work on getting good goals of care training for people to be able to navigate these conversations. So advanced care planning, as we all probably recognize, is looking into the future. So this is a values-based framework around how I wish to be cared for, knowing whether maybe it's the stage of my life and I don't really have any acknowledged illnesses, or I'm really healthy, no pills, nothing. These are my values going forward. It's more abstract. It could be more specific too. People with ALS will do advanced care planning, and they have a sense that in 2 to 5 years, they are going to be navigating problems with feeding, communication, mobility, etc. Goals of care are in real time. They're at the moment. This is where in the emergency room, we can acknowledge advanced care planning. I think it's important. Goals of care can change everything. That can be a real-time thing. So they are not the same. Probably a lot of people recognize this on the call. I've said this already. I got an okay from my colleagues in palliative care to put this slide in. I think it's a bit dark, but I just want to emphasize that palliative care is not end-of-life care. I'm going to get back to the cases so we have some time to talk and take any questions. So again, this is the 80-year-old man with dementia who probably had a very bad aspiration event in his long-term care facility and was brought into hospital for a limited resuscitation. So the patient was successfully resuscitated in the emergency room with non-invasive oxygen measures, fluids, antibiotics. I was called at 4:30 for a consult. The emergency doctor did an excellent job. I asked if I needed to come in at that minute. He said, no, things are trending better. He's now on just regular oxygen. His goals of care now are consistent with DNR level 1, which means that no further invasive tests or treatments are going to be done. It's best supportive care, good symptom management. That being said, within that framework, he was going to have a time-limited trial of treatment So he'd stay on a trial of antibiotics and fluids with limited oxygen so that family could come say goodbye. So I remember when I saw this person with the resident early that morning, I said, I bet this man will do just fine. I bet he'll do just fine. Not dying. I guess I don't have a conclusion, but I will tell you 5 days later, he went back to his long-term care facility happily. Okay? This may happen again. Could happen again. Case two. So this is the 47-year-old woman with a thymic cancer, spinal cord compression that got better. I was worried about this weird entity called myasthenia gravis, which is a type of paraneoplastic syndrome that can affect the body's motor function, so how people move, and the nerves that affect our muscles. It's fairly specific to this type of cancer. So with that thought in mind, I'm not a neurologist, so I asked the neurology team to see this person ASAP, which they did, and they got back to me and confirmed my suspicion. This woman came in as a full code. She's a young mother with a scary diagnosis of an incurable but slow growing cancer. We had a talk initially about moving to DNR4, and here what that means is that she'd be open to critical care measures, but not to be on a breathing machine and not to have CPR for heart stops. Subsequently, though, when my worries were more or less confirmed by the neurology team, I actually said to her, listen, I think you should be open to intubation. Things could get worse before they get better. And there are treatments for this. So went from DNR full code to DNR4, and I recommended DNR5, and she agreed to that. She was admitted to our unit with CCOT, which is the critical care outreach team following. I actually wanted her to go to the high acuity unit, which is a step down unit for monitoring, because I worried that she was going to get worse in the coming days and hours. But she lasted about 6 days on our unit, largely doing well until she wasn't, and then had to go to the ICU. She did actually have to be intubated for several days with her treatment, but she's now extubated, happy, I will say thriving. Very good news story. Before I get to takeaways, well, I'll do takeaways quickly, and then I want to end with something that happened this morning. So emphasizing that palliative care in the emergency room is a reality in 2026, and it has been for some time. So we need to be good at it. The modern emergency room, there's a lot of advanced care. So it is a place where we can actually make a difference. Things have improved. We are more educated in the emergency room to deal with palliative care, but there is a lot of work to be done. In fact, this afternoon, I have a meeting with one of our provincial program directors for emergency medicine, just talking about this topic and making sure it stays as a point of emphasis. There are pre-hospital options for palliative care. Know that when you call an ambulance. Remembering that palliative care is not hospice care. It's not the same. And that do not resuscitate does not mean you don't intervene. Lastly, before questions and looking at the chat, I want to talk about the medical pause for a second. So I bet you a lot of people on the meeting are familiar with the medical pause. We actually just did one this morning with one of our patients who died at about 8 o'clock with family in the room. And this has been a really important, very brief intervention that we brought to the emergency room, I don't know, more than 10 years ago. I won't say we're batting 1,000. We don't always do it. But a medical pause essentially gets us all, whether we're in the ER, the ICU, medical floor. We do this in hospice too, where we pause and acknowledge that person as a human. And I think, if we have a big traumatic arrest or cardiac arrest, we'll often have families in that resuscitation. And that can be a lot, but there's a lot of evidence to have that go on. But a medical pause, I've been blown away at how positive that has been, despite, the negativity of a death, expected or not. And it helps with burnout. It helps with families. It helps with loved ones. And it also helps us slow down a bit. So I would say don't forget a medical pause. I strongly encourage people to do it all the time if they're in an environment where there's an interface with life and death. And I think with that, I'm on time and available for questions if there are any. And I don't know, Esther, if you want me to stop sharing.
Yeah, you can go ahead. Thank you once again, Dr. David, for your presentation. And just bringing together the perspective from emergency medicine and also from palliative care. So many important points you've mentioned today. Just to let you know that the floor is open if you have any questions or we can entertain any discussion right now. You can put it in the chat, you can use the raise hand button, and I guess we'll be happy to answer you right away.
I see the question. Can I go into a little bit more detail about the medical pause? You know what? I can. In fact, I can read it. I keep the script on my phone because yeah. Let's see here. Okay, I'm gonna make it big because I don't have my eyeglasses with me, and if my wife's on this meeting, she's gonna laugh at me. So there's a script for family and not family, but essentially it's very quick. So this is what we did this morning, family at the bedside, and we said, let us take a moment to pause and honor the person. He was loved and loved. Sorry, he loved and was your family member and friend. In our own ways and in silence, let us take a moment to honor them. So we pause there. Let us also honor and recognize the care team, the care that was provided by our team. And then we have some more silence. And then we say thank you. It's that fast. So yeah, that's the medical pause. And I think you can find it kind of anywhere.
Thank you
Is it
so
okay,
much.
Esther, if I keep just working on the chat while there's a lot of chat?
Yeah, yeah.
Uh, What scales do you use in the emergency department to guide decisions about treatment limitation and goal concordant care? It's a big question. Scales. So, a lot of people in emergency room aren't familiar with scales like the Palliative Performance Scale. They will go we will go based on, let's use cancer as an example, medical records that will indicate where a patient's at in their care. And they may or may not have a lot of insight. They may be totally with it. There are a lot of scales. That way, I will say that when we talk about goal concordant care, we do have conflicts when it comes to proceeding or not proceeding with care. And one of the tools that I have utilized, and I'll just state, like, I have the luxury of working in a big hospital with big teams. Like, this isn't the reality for everyone, but I will often get other people's assessments in real time. For instance, the ICU or critical care team to see a patient early. If I think that the patient medically probably wouldn't benefit at all from being on let's say, a machine at the end of life, a ventilator, I will actually get a preemptive critical care consult if I can, because I think it's important to do it earlier than later. I'm not sure if that helps. A question from Janet: what are some pre-hospital palliative measures? So Janet, a lot of them has to do with medicines, actually. So what medicines are available? And if anyone's from BC Ambulance, feel free to speak up. So a lot of it had to do with access to medicines, largely from advanced care paramedics. So not the BLS paramedics, but medicines for pain, shortness of breath, confusion, delirium, nausea, and be able to deliver these medications in place so people don't need to be transferred. Um, Medical pause. I think I answered this. Question two, how can we encourage physicians and staff in the ER to see value additive palliative education? Um, yeah, I think it's advocacy. I do believe the awareness is there in the emergency medicine culture. It's some, depending on where you work, like there should be champions. Where I work, there were actually more than one emergency medicine palliative care doctor. So I think culturally, it was there, but it's not everywhere. Um, I organize palliative care education and mostly it is long-term care medical staff, but not in the ER. Okay, thank you. And thank you for your advocacy. I'll keep going. I don't know how much time I have. Okay, from Christina, what would you say to family members who insist in sending their loved ones to long-term or to the ER from long-term care? Yeah, it's a good question. It's an area of conflict. I think it probably used to, I don't know how much gray hair you can see. I got some grays. Like, I think a lot of this gray hair has come from conflicts like this over time. But I'm really in more of a chilled stance around this because, there's some things that just can't be managed at home or in long-term care. And we'd all agree that some people just shouldn't be moved. But I've kind of let that, you know what, go. I think that in long-term care, for instance, like the nursing ratios to patients is extraordinarily difficult, 50 to 1, or, depending on where you work. And I don't know how you effectively do your job when the person may need one-to-one care. So if that's the case and families are seeing it, like I don't blame people for coming in. So I've personally kind of let it go and just said, I've got a lot of tools here. I'm very lucky to have tools at 24 hours a day, unbelievable nurses. Like, man, I just feel privileged for that. Um, from Tracy, what are your thoughts on when the substitute decision maker does not follow the patient's advanced care directives? Okay, that's a spicy topic. I don't have a good answer for that, Tracy, but I will say that I feel very lucky that I can be a palliative care doctor and not an emergency medicine doctor when I'm having to deal with that, because really what I have as a total luxury in palliative care a lot of the time is time. And so one thing I got stressed about, I think inherently, is that I didn't always feel like I had enough time in the emergency room to navigate this. There was too much to do. You're looking after too many patients. And I found in the last years of when I was working, I would just stay late. I would just stay late and try and deal with stuff when I no longer had to see more patients. It's a tough question. Yeah, I'm just gonna say my bullet answer would be time. I just want more time to discuss things. I'm not conflict avoidant, but I'd prefer not to have a conflict. Um, okay, Kathleen was just saying that she loved the pause in the pit. Did they do the pause in the pit? That's great. Awesome. Okay, a long question from Jamie. I'll try, I've got some time. A major challenge in rural emergency medicine is navigating transfers for complex symptom management without disrupting patient goals of care or pulling. Do I have to read all this? Can everyone see the chat or?
Yeah.
Okay, I won't read it all out then. Let me just read it. Oh, wow. Yeah, I guess, Jamie, one option is having someone on the other end of the phone to call to see if we can help over the phone. I know I've been called on call. I'm on call a lot. Um, I've been called after hours around this stuff. I don't know if that helps to have like telemedicine support. Um, so urban rural coordination to keep care local. Yeah, I totally support that. And let's just give a shout out for our rural practitioners who frankly do everything. They just do everything. They're emergency physicians, obstetricians, palliative care doctors, you name it, psychiatrists. So yes, I agree with keeping people in place. I hope that we can be supportive. after hours to people, and I know that there's an after hours number. I just, if anyone else has it, I don't have it off the top of my head. And I'm scared to disrupt my screen and then I'll lose you guys. I see a question from Nell.
Hello.
Hi, Nell.
Hey, thank you so much for that presentation, Dr. Dave. My name is Sal. I'm from Toronto. You know what? I like that we integrated pop culture here on this.
You're muted,
Oh,
please.
sorry.
You're back.
I was gonna say thank you so much for that presentation, and I appreciate how we incorporated pop culture, particularly like the pit. Because I remember also utilizing that episode during my presentation in one of my grad school recently, talking about palliative care, and I really talks about all different aspects and domains about ethical issues, healthcare system issues, about palliative care in general. But I'd also like to get your thoughts about futility care, recognizing that people come into the emerge, with some issues, conditions, but to what extent do we recognize as a clinician that we are already providing a palliative approach to care versus this is more of like a futility care already?
Thanks for the question, Nell. So I'll start by saying I don't know if everyone agrees with this, but we're largely avoiding the term futile or futility in our language, at least in the hospital. It's not to say I like the word futile, and we will use it amongst each other in conversations on medical teams. Part of the issue with even using the term futile when it comes to communication is that medical abandonment is a real thing, and I really strive to avoid anyone sensing medical abandonment in communication, especially when I'm introducing palliative care. Because getting back to, if I'm introducing palliative care, a lot of people will be like, the team is giving up. The team is giving up. And so when it comes to non-beneficial care, that is a real problem. I I wouldn't say countless, counted cases, especially during the pandemic, where patients would come in, get transferred from a facility or home where they're getting essentially end of life care and brought in with COVID on top of it, and families being insistent on being put on a ventilator. A lot of conversations. And, you know, there's no one answer. This is a whole separate topic, a whole separate talk. I mean, I think just making sure that people understand that, we're going to do everything for your loved one that will benefit from them. And I try and bring that in early so that people feel that they're going to be cared for. So when we talk about doing everything, okay, everything's a big word, but everything that will benefit your loved one, it's a bit more specific. So we can talk about IV antibiotics, peripheral vasopressors, non-invasive oxygen measures, broad spectrum antibiotics. But there's some things that won't benefit your loved one, and that includes being on a machine at the end of life. That includes CPR when the heart stops naturally. Does this always work? No, it doesn't. It just really doesn't. But that's a real thing. And again, that's where I'm happy. I feel grateful for my training because I'm a bit better at these conversations than I was prior to 2013, but not perfect. And I probably fall on my face more than I know. I hope that helps now. Um, I think we've got a little bit time for Valerie's question here. Yeah. So this is about palliative care in the ED. And a lot of the theme of palliative care in the emergency room isn't about fixing the problem, making the person feel better. I agree with that. Healthcare providers administering ventilator pain control, something. Yeah. So I'll try and synthesize that, Valerie. Yeah, I totally agree. From a Hippocratic standpoint, when you can't fix a problem, at least you can make people feel better. And I think that sometimes we forget, and let's say we've got someone in very bad pulmonary edema, heart failure, they can't breathe. So we know what to do with these patients from an ER perspective. We put them on BiPAP, so non-invasive positive pressure ventilation mask. We give them medications to get water out of their lungs. We do all these things. But sometimes we forget that the patient's actually experiencing air hunger, which is a very central symptom from the brain. It's anxiety provoking, to give them something for their air hunger. And yes, traditionally we would give an opiate, but we probably need to give more opiates so that while we're trying to get them actually better, they can feel better at the same time. The same thing happens in pain too. We want to fix the traumatic problem, but we're just sometimes, I think we're better again, like we're slow to get the pain medication or the pain under control while we're fixing the broken femur or doing something like that. But yeah, point taken. And I think I have 20 seconds left, so I probably should call it. Hey, Esther?
Yeah, thank you so much, David. Your presentation has been so insightful, and also for sharing your experience with us today. So I'm just being mindful of our time today. So before we wrap up, I'd just like to invite you to complete a short evaluation survey that would appear when you exit the session, as your feedback will be very important for us to understand what's working well and how we can continue to improve our echo sessions. We also aim to share the session recording, the summary notes, and any other additional resources within the next 7 days. So we just encourage you to keep an eye on your email for these materials. And you can also check our center's website for more information about upcoming echo sessions. Right now, I'll just share in the chat box our next echo session, which will be the 10th of September, titled Fostering a Palliative Approach in Rural Hospice Palliative Care. And we'll have Gail Potter as our presenter. Thank you everyone once again for joining us today. We hope you found the session valuable, and we look forward to seeing you at the future echo session. Have a wonderful day, everyone. Thank you. Thanks, David.